Hello, my name is Jonathan Ng, PharmD candidate of 2024, courtesy of Roseman University, and today I'll be presenting on guideline review for a spontaneous intracerebral hemorrhage and management of patients here at Centennial Hills, as this is my current 3.5 rotation. Now, the reasons why I'm presenting today have to do with the fact that I'm currently on rotation here at the ICU. Here at the ICU, a lot of patients come in with brain bleeds just because of the fact they need constant monitoring for said condition. It's very, very important, so in that way we can make sure that the patients have optimal outcomes considering the condition that they're currently in. Along with Centennial Hills, here we are the best neurological ICU and neurological care center in that of all the Las Vegas Valley. Therefore, we do see considerable amounts of patients that do have brain bleeds, just intracranial hemorrhages, or just stroke in general, transischemic stroke, to state a few. And there is also, which is why it's very important that this update that was updated as of 2022 from the current original 2015 needs to be stated and needs to be reaffirmed that this is very important. Now, before I begin, I just wanted to say what I'm basing all of this presentation on. I'm basing it upon recommendations and quality of evidence, just because classes of different recommendation is seen by current usefulness, how beneficial it is, reducing mortality, morbidity in patient populations in general, as stated from the evidence, which is the literature that has currently been published. So now we'll be able to reaffirm this not only based upon personal experience, but also based upon hard clinical studies that have been proven to show efficacy for the recommendations that are being made. The layout of this presentation will be in 4 different parts. It will be pathophysiology, diagnosis, treatment, and long-term care. Pathophysiology, just wanted to make this clear point first. There is a distinguishing difference between intracerebral hemorrhage and intracranial hemorrhage. Intracerebral hemorrhage is isolated to that of the brain. Intracerebral hemorrhage is that of a type of intracranial hemorrhage. Intracranial hemorrhage is a general term that refers to the entire cranium and bleeds that can occur. There can be bleeds in the meninges, for example, subarachnoid, subdural, and just different aspects of the skull, of the cranium for that matter, that can bleed, compared to that of intracerebral hemorrhage, which is the bleed of the brain directly. And the reason why an intracerebral hemorrhage will occur is based upon 2 categories of that pathophysiology: arteriosclerosis and cerebral amyloid angiopathy. So, arteriosclerosis is a process that happens typically later in age and can be affected by other factors, for example, alcoholism and diabetes. Just because what happens is the deep penetrating coronary vessels in the brain begin to have deposits over time, whether they be lipids, they can be different proteins, mediators, which then causes an immune response, which then will lead to plaque buildup on that of the vessels, which then will lead to them hardening. And it's due to this hardening with the added factor of hypertension that can lead to the cell wall rupture. The walls of the vessels cannot take being elastic anymore because of this hardening, therefore they just burst. The other factor that is involved with this hardening of the vessels has to do with cerebral amyloid angiopathy, which is the accumulation of, typically in dementia patients, they have this protein called amyloid beta peptide that begins to build on the blood vessel walls. And it's because of this that we don't really understand most of it, but we understand that this protein does cause accumulation on the vessels. Doesn't necessarily make them harder, but it induces the degradation of the walls, therefore leading to the bleed as seen by this image right here. Now, the etiology, why should you care? 795,000 strokes a year in the United States of America, 10% of them are intracerebral hemorrhages. Within the first 30 days, 40% of the patients will die. And the majority of the people who survive are severely disabled for the rest of their lives. Arteriosclerosis and cerebral angiopathy constitutes 85% of all spontaneous intracerebral cases. Now, in terms of populations, as stated previously, mostly older folks, 55 years or older, individuals of African descent, and that of Asian Americans, particularly Japanese Americans, as stated in research, not just genetic predisposition, but also chronic hypertension and history of alcoholism have been correlated with that of increased risk for that of this condition. Populations that are affected are typically lower socioeconomic class as well, typically citizens of lower developed countries. For example, when studying various countries in East Asia to that of their more developed counterparts, or that of looking at South America compared to North American counterparts, we can see that individuals of lower socioeconomical classes and different availability to resources are more likely to have this condition. Diagnosis includes the usage of MRI or CT, as seen from this image right here. There's this nice blot right here, which shows that there's a hematoma. The hemorrhage has been occurring in this part of the brain within the first 24 hours to show symptom onset. Diagnosis, we can also use labs in order to show more correlation. For example, if we suspect there might be something else, such as looking at prothrombin time, partial thromboplastin time, PTT, and internationalized normalized ratio, also known as INR. Typically when these numbers are higher, it shows that there's higher risk of bleeding, higher risk that if, for example, in a traumatic injury where there's a cut that occurs, it'll take longer times for bleeding, typically shows that there is more chance that there is a brain bleed that has occurred, along with ruling out other conditions that might be the cause of it, such as hypoglycemia, as this condition is very highly correlated with that of being confused with stroke, which is why a simple finger prick and checking blood glucose is important when the patient is first admitted to that of the ER before being escalated for higher treatment. Now, in terms of treatment scale, it will go into these parts: blood pressure management, anticoagulant-related hemorrhage, antiplatelet-related hemorrhage, specialized inpatient care, thrombosis and thromboprophylaxis, glucose management, temperature management, seizure prophylaxis, hyperosmolar therapy, and surgical intervention. Blood pressure management, it's important to control the blood pressure, especially during the first 2 hours, as this is an active bleed that's happening in the brain. And if this is not controlled, it can lead to increased pressure and then damage to the brain thereof with the increasing hematoma. Initiates the treatment with that of medications with fast onset and short duration. This way, when giving medication, we don't quote unquote overshoot blood pressure management because of the fact that we have the ability to control for such. Maintaining mild to moderate ICH with a target of 140 systolic millim of mercury. Blood pressure monitoring for large or severe ICH is not really well established, therefore we go off of guidelines as stated right here. Making sure that the blood pressure is within the range of 130 to 150 if it is higher than systolic of 160. But always making sure that it is no lower than 130 millimeters of mercury, just because that can be very detrimental to the patient's health overall. As seen from this graph right here, anticoagulant-related hemorrhage, vitamin K, dabigatran, DOACs, and heparin. It is recommended for patients that are on anticoagulant therapy to immediately be discontinued from anything that they're on. In the case of warfarin, the vitamin K antagonist, they are to be given Kcentra, also known as prothrombin complex concentrate, for rapid conversion as soon as possible. They should also be given vitamin K administration with this medication, so that we can induce clotting factors, so that way the patient will not have any risk of bleed anymore, but be able to clot and to plug the quote-unquote break that happened in the arterial vessel wall of the brain. If the patient has an INR of 1.3 to 1.9, normal is 1.0, it's reasonable to give Kcentra to gain rapid correction and reduce hematoma expansion. With DOACs, for example, Eliquis or Xarelto, it is reasonable to give Andexxa. However, it's more common to give Kcentra just because Andexxa is very expensive, $59,000 compared to that of its counterpart, Kcentra, as stated previously, which is around $5,000 per patient in treatment. Also using idarucimab as anticoagulant for dabigatran, as dabigatran is a different mechanism of action, therefore is required for different treatment. Heparin as well, if the patient has received a dose within 2 to 3 hours, it's reasonable to give protamine 100 units of heparin per 1 gram of protamine for adequate reversal if administered within the last 2 to 3 hours. Then for Lovenox or low molecular weight heparin, protamine is reasonable for partial reversing, ergo the reason why pertinent treatment is very necessary. Then for antiplatelet-related hemorrhage, it is required for the patient to get platelet transfusion. If the patient is taking aspirin and in need of neurosurgery, it needs to be started stat. However, if the patient has been taking aspirin and not scheduled for neurosurgery, it can be harmful to do this just because there's not really preparation for anything and there is a lot of other medications that can interfere. Therefore, it's only until there's emergency or the use it or just liability in general. Specialized inpatient care is optimal. As seen here at Centennial Hills ICU, we have our own part of the hospital that specializes in intracerebral hemorrhage management, and this is very important for that of positive patient outcomes. In order to prevent complications, it helps to have a set protocol and orders along with to increase oral intake as soon as possible, just because we want to make sure that patients are also not becoming delirious, not becoming unaware of their surroundings, because being in the ER and being in the state that they're in, they need to be able to still be using parts of their brain so that they can remain active. Treatment of thrombosis includes the usage of an IVC filter as a bridge for patients that are not candidates of anticoagulation. This is very important because putting in that inferior vena cava filter to stop the circulation of clots that can occur that can lead to a pulmonary embolism or venous thrombolytic embolism is very important, as this increases complications which can lead to greater problems later down the road. And then it's okay for us to delay fractionate heparin or Lovenox for 1 to 2 weeks after onset, just because we're concerned about increasing bleeds. Thromboprophylaxis, it's recommended top and number 1. Always use intermittent pneumatic compression, otherwise known as mechanical prophylaxis, in the form of sequential compression devices, in order to have prevention of clot buildup of the patient's overall health. It's less important to have heparin or Lovenox just because these two medications, they can't easily be reversed unless they're given protamine directly. With these sequential compression devices like little stockings that keep compressing the calves, and that way circulates blood, it's much easier to give to patients than, say, administering medications with the risk that this might happen. And for glucose management, it's recommended to remain constant glucose monitoring, just because hypoglycemia, as seen beforehand, has very, very stroke-like symptoms, as seen 40 to 60 milligrams per deciliter. And then tissue hyperglycemia, which is rated on 180 to 200 in terms of its effect on serum glucose. For temperature management, it's recommended to treat elevated temperature to improve functional outcomes, and the usefulness of therapeutic hypothermia is still widely debated amongst physicians just because there's not a lot of evidence to support it. Now for seizure treatment, constant monitoring of the brain via EEG is recommended, especially for patients that have exhibited seizures in the past, just because treatment needs to be settled out, as patients can cause damage to themselves or to their own physical stature, just because this can lead to further complications later down the road. For hyperosmolar therapy, it's recommended to have ventricular drainage, to have, as they call it, a probe sent into the ventricle to start to release the excess fluids, so that way pressure does not occur, which can lead to damage of the brain. It is recommended to use hyperosmolar therapy in the form of 3% sodium chloride solution or mannitol, or also comes in 23.4% sodium chloride solution, as well as 7% sodium chloride solution for being able to reduce the intracranial pressure. Bolus hyperosmolar therapy is considered for briefly reducing the intracerebral hemorrhage. It is not recommended to use corticosteroids for that intracerebral hemorrhage. However, for subarachnoid hemorrhage, it has been widely used and is recommended. Surgical interventions include the usage of surgery in the form of external ventricular drain, as stated beforehand, and then the usage of a craniotomy, the removal of a portion of the skull, so in that way it can reduce pressure in the various other parts, as seen from this flowchart. Different situations call for different measures to be done. For example, external ventricular drain for this condition right here, and the latter. Now, for long-term treatment, it's recommended very, very good transition of care to make sure that you have discharge managers that are able to get onto this as soon as possible, as patients who have elongated stays in the hospital are known to have less positive outcomes. As seen, early discharge is beneficial for patients to increase independence. For behavioral complications, a lot of patients who have moderate to severe depression already, it's recommended that they seek therapy in the form of CBT, cognitive behavioral therapy, or that of pharmacotherapy in the form of SSRIs, SNRIs, or benzodiazepines if need be. Especially for patients with anxiety, there should be screening tools to locate depression and anxiety where it does occur, so in that way patients can seek treatment and be treated accordingly. Secondary prevention includes reducing intake of alcohol, exercise, making sure that patients control their LDL levels to prevent the accumulation of lipids on the vessel walls. It is also recommended for blood pressure control to make sure the patients do pertain to AHA guidelines in that regard to maintain their blood pressure, so then there is not as high of a risk, as that is number one risk of intracerebral hemorrhage. And there's my references. Any questions? I'm currently looking for a residency in oncology, not transitions of care, but I was thinking more along the lines of admin or possibly informatics. Hope you like this presentation. Please email me any questions or text based upon how you got this video, and thank you for your time.